Okay, so good evening, all the participants. Warm greetings. On behalf of the editorial board, JIPS committee, I welcome you all to this yet another episode of General Club of JIPS, the 8th episode to be in particular. Before we delve into all the three manuscripts, which have been handpicked by our two of esteemed moderators for today, Dr. VVS Chandrasekharan and Dr. M. Srinivas Rao. I would request our editor-in-chief, Dr. Rasik Shah sir, to for a brief introductory remarks. Dr. Rasik Shah sir.
Yeah, thank you, Manoj, for starting this JIAPS Abhigyan episode 8. Over last 2.5 years after I took over, the work of JIAPS is continuously increasing. When I say increasing means the number of submission is almost double or it will double this year. When I took over, it was 170, 180 submission in a year. Last year, that is 2024, we had submission of 310 articles or manuscripts. This year, it appears as of now, we are at, I think, 130, 140. So if we continue at the same rate, it will probably go to 340, 350. Now, what does that mean? When the submission increases, the acceptance is going to increase. When acceptance is increased, it means that the expenses of the JIAPs is going to increase because everything is depending upon the number of pages which are published in JIAPS. The expense will be in the range of about 3,000 rupees per page. So if we are publishing about 800 pages, the expense will be in the range of 22 to 24 lakhs. And if it is 900 pages, it will be 24 to 27 lakhs. Now, this is a large amount. We could get away when I took over by getting rid of printing of JIAPS to all the members. Instead of that, we said, please log on to the website and read, which majority or everybody agreed to that, and I am thankful for that. Now, because of that, we will be able to continue with this increase in the submission and acceptance ratio. But going forward, we may not be able to sustain that. So we'll have to find the sources of new income in the form of advertisement and donation. Last year, I did not do a lot of uh, uh, initiation or discussion on that because we were okay. But going forward, we will have to look into the finances again. One of the suggestions which I had to the IAPS, which I will send the formally later, that 30 years back, IAPS finances were not strong, and editor-in-chief had responsibility to uh, take care of the finances. But going forward, today, finances of IAPS are quite healthy, and we should be able to sustain that with the help of IAPS. There is a IAPS contribution which is significant, and that is the reason why we are able to sustain it. And I have completed 2.5 years. My next 2.5 years will be done without much problem. But in future, we will have to think about that so that whoever is going to be next editor-in-chief, he is not worried about the financial aspect. That is one part. Second part, which I want to inform the members is that all the reviewers are going to get the credit now. So I request all of you that please review because you are going to get the credit on the website. And if you don't know how to review, then please, I'd send the link today. Take that class of 3 hours. It will definitely help you, which is free of charge. And when many people they review and they have a lot of remarks, but they don't review it again, even when the article is sent it to you people. So when it comes back to you, please go through that. It doesn't take many, when you have already reviewed and when author sends back the remarks, please just go through that. It may not take more than 5 to 10 minutes of your time. So please complete that. So then, the process of publication or decision making becomes a faster. So with this request, I will request to Manoj to take over and continue with the proceedings. Thank you. Thank you, everybody.
Thank you, Rasikshar, for that very valuable information. And it's a matter of great pride that in your hands, your tenure, the journal has progressed so much, both in terms of submission of manuscripts plus the finances. We have two very esteemed moderators for today's session, Dr. VVS Chandrasekharan from Hyderabad and Dr. Srinivas Rao from Vizag. Both obviously needs no introduction. I would request them to take over this session and start with all the three manuscripts. Dr. Srinivas, I think Dr. VVS has not joined yet. Srinivas Rao, you can start.
VVS is also.
Yeah. Hello. Am I audible?
Yeah, you are.
Yes, yeah. So may I invite the first speaker? We chose 3 topics from this month's JIPS, basing on the novelty and the work they have put in these papers. The first paper is from the AIMS Jodhpur, written by Dr. C. Lakshmi and Arvind Sinha. It is about the comparison of the systematic bladder morphology and the pressures in neurogenic bladder. So instead of measuring the pressures in the urodynamic studies, they evaluated the anatomy of the bladder in cystogram, and they have narrated the correlation between the pressures and the anatomy of the bladder. So Dr. Sri Lakshmi is going to present the article. Dr. Sri Lakshmi, please go ahead.
Yes, sir. Good evening, everyone. I'm Sri Lakshmi from AIMS Jodhpur. Greetings to you all. So I am here to present our
Dr. Sri Lakshmi, you're already co-host. You can share the presentation, please.
yes, sir. I'm having some difficulty with the sharing of the screen. Just give me 2 minutes, sir. I'm sorry for the inconvenience.
Welcome, Dr. Chandrasekhar. Are you driving or at home?
I've reached.
Yeah, sure.
No, I've reached and I've logged in about 10 minutes ago.
Yeah, sure. Thanks. Thank you. We just started with the first paper by Sri Lakshmi.
Yes.
Yes, sir. Is my screen?
Yeah, it is seen. We can see it. Please go ahead.
Yes, sir.
Yeah.
So in our review regarding the evolution of scientific efforts to define the systematic bladder morphology in the neurogenic bladder. So in the next 10 minutes, I'm going to discuss regarding the review, which have been published here. So So as we know, UDS becomes a mandatory investigation during the follow-up of neurogenic bladder. So as to identify the high pressure bladder earlier and avoid the upper tract deterioration. And since UDS is a very tedious procedure, because considering the invasiveness of the procedure and it is difficult to perform in the children and non-availability of the investigation makes it a very challenging procedure to do. So can we resort to some screening investigations which can help us identify identify the high pressure bladder. But there is no definitive screening investigation per se, and coming to the morphology of the bladder, can we employ this as a screening investigation? So with this question in the mind, we went ahead with the review. So as we know, because of the loss of bladder sensation and inability to initiate voiding and detrusor sphincter dyssynergia, the bladder in high pressure system, it becomes a vertically elongated trabeculated bladder, which is classically described as a Christmas tree or a pine tree bladder. So the major cause for this is the middle circular layer of the detrusor muscle, which becomes constricted and leading to the vertical elongation of the bladder, sometimes even causing an hourglass shape of the bladder. So in this review, we were exploring the development of scientific endeavors to define the bladder morphology in the neurogenic bladder and the current state where we have the evidence regarding the correlation of the shape of the bladder with the detrusor pressure and upper tract changes. So that we can see over the last 50 to 60 years, there have been multiple studies that have been done, and there is a evolution in the same topic. So initial first few 30 to 40 years, there were just a subjective description of the bladder morphology, followed by some studies where grading of the bladder trabeculation was attempted, followed by recent studies where objective measurements of bladder morphology has been identified, and it has even been correlated with the detrusor pressure. So the first phase, as we saw, there was subjective description of the bladder morphology. One of the remarkable study is by Fredenberg and Ney in 1961. So here they evaluated 50 cystograms of patients with neurogenic bladder, and they attempted to define the bladder morphology in the descriptive terms based on the shape of the bladder, shape of the urethra, and the bladder neck. So here it was not a grading system per se. Here they had just enumerated the shape of the bladder, like a large atonic bladder or an hourglass bladder, pine-shaped bladder, or a severely contracted bladder. They were able to identify in the 50 patients from their cohort. So later in 1991, Ogawa et al., they identified the grading system for this bladder morphology and described a grading system and correlated that with the bladder upper tract damage with the kidney. So as we can see in the grading system, from grade 0 to grade 3, we can appreciate that the size of shape of the bladder went on becoming elongated and vertically elongated. Along with that, there were appearance of the trabeculation as well. So this is the linear diagram showing the same. So, and when they evaluated that and correlated that with the upper tract deterioration, as the grade of the bladder deformity increased, the incidences of upper tract deterioration were higher, ranging from 52 to 62%. So as we can see, this was a good study depicting the grading as well as correlating that with the upper tract deterioration. But the drawback that with this study was it relied on the subjective appearance of the bladder deformity, and there was no objective description for the grading system. So in the later stage, there were addition of the grading for the bladder trabeculation in few studies. So one of the study was by Corey et al. Here, what they did was they graded the bladder trabeculation and used that as a gauge for the outlet resistance. As we know, with the increase in the outlet resistance, there will be appearance of the trabeculation, and it was graded as mild and severe. So though they employed this grading system for evaluation and regarding the requirement of bladder outlet surgeries during the augmentation for neurogenic bladder, this was one of the grading system from the early times, and it was again a subjective grading and not an objective grading. It was by Selby et al. In 2020, where they gave a more of an objective description for bladder trabeculation. So this grading system had a good inter-rater reliability also, and they have validated this grading system as well. So this grading system, as we can see, had grade 0, 1, and 2. Grade 1 having a bladder wall where there was appearance of saccules or diverticula without the neck. But whereas in the grade 2, there were appearance of the necks for the saccules and diverticulum as well. So this was a very good grading system with an objective way of grading as well. But however, the drawback this study carried was it did not correlate with the bladder pressure or upper tract deterioration. So, and it was difficult to reproduce them as well. So in the recent times, that is after 2020 onwards, there were few landmark studies like by Kumano et al. And Aital et al., where they employed objective measurement of the bladder morphology and correlated that with the bladder pressure as well. So coming to the objective measurement, as we can see, the objective measurement they had employed in both the studies were height to width ratio. So what is this height to width ratio? As you can see in the image, so it was the ratio between the maximum height of the bladder to the maximum width of the bladder at maximum cystometric capacity. So it was one of the objective measure where we can define the bladder deformity. So as we know that neurogenic bladder is a pine-shaped or a Christmas tree pattern, which is a vertically elongated bladder. So with this ratio, what we can conclude is, what we can obtain is that taller the bladder, higher the HWR. So the height to width ratio will be more in the tall bladder. So can this tool be used as a screening investigation to identify the high pressure bladder? So with this in mind, a study by Kumano et al. Was done, and here they employed a definition of more than 40 centimeter of maximum detrusor pressure as a high pressure bladder and less than 40 centimeter as a low pressure bladder. And in this study, they found that there was a significantly higher HWR in the patients with high pressure bladder. If the pressure was more than 40 centimeter of water, their height to width ratio, median height to width ratio was 1.5, which was 1.37 for low pressure bladder. And with the cutoff of 1.4, the sensitivity of the height to width ratio to sensitivity and specificity was 87% and 56.6% to identify the high pressure bladder. So all these description of morphological changes like trabeculation or a vertically elongated bladder, all these morphological changes will take some time to appear in the bladder, and it can in turn delay the diagnosis and again change the purpose for the challenge the purpose for screening tool, employing it as a screening tool. So there is one study by Hall et al. Where they said that 99.9% of the physiological storage of the bladder, it should occur below 30 centimeter of water. So as we know, the definition for high pressure bladder is more than 40 centimeter of water. So between this 30 to 40 is where the bladder pressure will become unsafe, and it is non-physiological as well. So what we did in our study was, can this tool, that is a bladder height to width ratio, can it be used as a surrogate marker to identify the non-physiological storage pressure as well? That is, if the pressure is more than 30 centimeter of water or not. So what we found was that the height to width ratio was significantly higher when the it was significantly higher when the bladder pressure was more than 30 centimeter of water, and it was 1.26 when the bladder pressure was less than 30 centimeter of water. And with the cutoff of 1.3, we were able to identify the non-physiological bladder pressure, and it had a sensitivity of 87.5% and specificity of 48.2%. Again, it necessitates that the diagnosis of high pressure bladder or a non-physiological pressure, it requires a performance of UDS. But what we are trying to say is that height to width ratio, it can be used as a screening tool as well. So when the height to width ratio was less than 1.3, in our cohort, there were around 17 patients, and only one of them had a upper tract deterioration, and the mean pressure in these patients were 19. Whereas if the height to width ratio was more than 1.3, it had almost 36 patients, and the mean maximum detrusor pressure in this cohort was 39. So indicating that with the increase in the height to width ratio, the pressure went on increasing. So in both the studies by Kumano et al. And Aithal et al., they found that with increase in the bladder pressure, there was a linear increase in the height to width ratio. So with the cutoff of 30, the height to width ratio was 1.3, and with the cutoff of 40, the height to width ratio went up to 1.4. So height to width ratio can be used as a reproducible measure for screening for non-physiological bladder pressure. So to conclude my presentation, over the years, the evolution has been made in an attempt to describe the morphology of the neurogenic bladder, and it can be simply classified into three phases, like a initial simple subjective description of morphology, followed by partial objective measures where grading of trabeculation was employed, followed by the objective measures where height to width ratio has been employed. So this height to width ratio can be a reproducible tool, and it can be used as a screening tool for non-physiological bladder pressure. So thank you so much.
Yeah, good one, Dr. Sri Lakshmi. At any point, have you tried the Is there surgical interference or medical treatment in these babies? What is the, kind of, what is it you are trying to say other than the screening tool for this?
Sir,
If you,
sorry. Yes,
yeah,
sir.
if you have to interfere surgically, do we rely on this, or you confirm the pressures with the UDS?
Yes, sir. Like I
Yeah,
mentioned,
yeah.
this can be a screening tool,
A screening tool, yeah.
but it is not a diagnostic one. The diagnosis of high pressure, as in the pressure monitoring, and this requires UDS performing the UDS. So when in a facility where the UDS is not available, a simple glance at the cystogram, which is usually performed everywhere, can help us directing towards presence of a high pressure bladder. So which again necessitates more intervention and more evaluation with UDS.
Yeah, right. Anyone? That's answered.
Yeah.
Yeah, please.
Good evening. It's an interesting study. I mean, so from what I understand, you published a paper on this last year in PSI, and this time in JIAPS, you did a narrative review,
Yes, sir.
isn't it?
Yes, sir.
So, from your narrative review, you are now concluding that the best parameter is probably the height to width ratio of the bladder,
Yes.
not the classification based on the trabeculations, grade 1, grade 2.
Yes.
So did anybody, including you, did they compare these two, the height to width ratio versus the grading proposed by earlier authors?
No, sir. Actually, that was one of the drawback of these studies. We have just used height to width ratio, and when we compare the height to width ratio, we're not taking into consideration the trabeculation as well, which is again a very important measure indicating the high pressure. So I think further studies employing both of them, the grading of trabeculation and height to width ratio, can be done, and that can give us a more better idea about the pressure, bladder pressure. So.
Yeah, I fully agree that we need a simple way to catch those children who are at a high risk of upper tract damage, meaning who have high pressure bladders.
Yes, sir.
So, does the presence of reflux have any bearing on this?
Yes, and actually,
Has that been studied?
No, sir. We have excluded the patients with reflux in both the studies, because appearance of reflux, vesicoelatory reflux, can alter the dynamics of the bladder pressure. So that has been excluded. All patients with reflux have been excluded from the study cohort.
Oh, I thought the presence of reflux would mean a high pressure bladder.
Yes, sir. So we and appearance of a reflux can alter the dynamics, as in when we are doing the UDS.
That's okay.
Yes, sir. So
I
that
agree.
we have not included that in the study population.
The study population.
Yes, sir. That was one of the exclusion criteria for us.
Interesting. The only problem is even your paper published in 2024 had a specificity of less than 50%, if I'm right.
Yes, sir. Yes, sir.
I think is a pretty low specificity.
Yes, sir.
So I think can we conclude that as on today, the gold standard is still urodynamic studies, and we should not rely on these bladder shapes and whatever as far as possible.
Yes, sir. Even with the height to width ratio, it will be just an indicator that it could be a high pressure bladder when the system for UDS, when the availability for UDS is not there. But even with height to width ratio of more than 1.3, we still have to go for UDS to measure the bladder pressure, because that is the investigation that has to guide through the further management of the patient.
Can I go as far as to say that a unit which does not have access to urodynamic studies should not be managing urogenic bladders?
Yes, sir. So that could be the referral criteria, if they can employ.
As on today, we don't have a simple parameter to actually say that whether we are dealing with a high pressure bladder or not.
Yes, sir. A further study might be required, which can involve both height to width ratio and trabeculation. But even then, the UDS will become a necessity investigation to perform, sir.
Investigation.
Can I ask a couple of questions just to understand? What is normal ratio?
Yes, sir. We do not have the normograms for the height to width ratio as well. So that is one of the other drawback. So the normogram is not defined for this height to width ratio.
Can we say that if it is less than 1.3, then they don't need UDS or any intervention as such, or even that cannot be concluded?
So like we discussed, specificity is very low for the height to width ratio. So again, it cannot conclude that with the this thing ratio of less than 1.3, the diagnosis of high pressure can be ruled out. So this is so it is not a conclusive this thing. So
Okay, thank you.
How did you get at this ratio? Did you do an ROC curve analysis?
Yes, sir. We did an ROC where and that with that we got the ratios, the cutoff.
And lastly, are you an MCH student?
Yes, sir.
What's the difference between systematic review and narrative review?
Sir, in the systematic review, there will be more of we have to do the forest plot and we have to do the forest plotting and a statistical analysis has to be done, sir.
No, I think given a narrative review, there has to be some kind of an analysis. Anyway, it will be interesting. Maybe you probably will.
Yes, sir. Yes, sir. Yes, sir.
But very nice paper and very nice concept.
Thank you, sir.
Yeah.
So,
No.
can I ask?
आज सीधे घर चलेंगे क्योंकि
Hello?
पैसे नहीं लाए आज पैसे नहीं लाए
At the end of this presentation, is there any use of using this ratio in practice in the management or assessment of neurogenic bladder?
Sir, in the patients who are, especially when we are managing the follow patients of spina bifida or spinal dystrophism, where we are to encounter the neurogenic bladder. So if we are practicing in a peripheral center where the UDS is not there, this can be a guide for a referral or an indicator to perform UDS. So it can help us in guiding the further management, sir. But it is not a diagnostic tool.
No, you yourself have answered that to the question of Dr. Resik, that we are not sure of the normal ratio of
Yes.
length to width, and we cannot say if the ratio is less than 1.3. There is necessity or there is high pressure bladder.
Yes, sir, but it can still be an indicator because we have a sensitivity of 87%. And from our cohort, what we saw is if the height to width ratio was more than 1.3, the pressure was around 39 in those patients and mean pressure. And if the height to width ratio was less than 1.3, the mean pressure was only 19. So there is a difference, but the normogram is still not yet established. So we can also work towards that, maybe.
So finally, can we take a message that if the ratio is more than 1.3, there is a rise in pressure inside the bladder?
Yes, sir. With as we saw from the studies that with the 1.3 as a cutoff, the pressure was 30, and with 1.4 as a cutoff, the pressure went up to 40. There is a linear correlation between the pressure and the height to width ratio, which we got in our study as well. So there is a correlation, but normogram is still not established. So that is true, sir.
Thank you.
Do we have the time for small comment?
Yeah, please.
I think Dr. Zamir has written in the question, the chat box that it is too harsh to say that one should not manage. I did not say that, but I said still urodynamics is the gold standard, and we still do not have a reasonably sensitive and both sensitive and specific, simple, non-invasive. So, Sri Lakshmi, can you think of a simple bedside, a non-invasive investigation which can give you a clue whether we are dealing with a high pressure bladder or not?
So one thing is instilling the saline in the bladder and checking for the compliance is one.
Non-invasive, I said non-invasive.
Non-invasive. Bladder filling with the ultrasound. With ultrasound, we can look for the distension of the bladder, which can again comment us on the non-compliance.
So what are you ultimately trying to see if there is a high pressure bladder? You're looking at the upper tract damage, isn't it?
Okay. So
Yes.
ultrasound
I
can
can
give
do
us
an
some guidance.
ultrasound. If it's, there's no hydronephrosis on both sides, then I can coolly take it that this is not a high pressure bladder.
Yes, sir, but sometimes it's possible that the appearance of a ultrasound can it is almost like a later stage when we are diagnosing the high pressure bladder. So to diagnose them earlier, it will be better to resort to some follow-up investigations, I think.
No. What I'm saying is a simple non-invasive bedside test. I do an ultrasound on a child. The child has spick and span normal kidneys, no hydronephrosis.
Yes,
At
sir.
least I know that we are not really dealing with a bad bladder.
Yes, sir. Yes.
Yeah.
Probably a much simpler test, and than calculating. I mean, I'm sure this is useful, but then
Yes.
I think the sensitivity is reasonable, but specificity is very low. So that's the problem.
Yes, sir.
Anyway, very nice concept. Thank you so much.
Thank you, sir.
And finally, if you can compare these systometric appearance along with the UDS as a study, then we will know what pressure the changes in the bladder anatomy is occurring.
In that study, sir, we have compared the height to width ratio with the bladder pressure, but
Right.
trabeculation has not been included in the study, sir.
Yeah, sure. So thanks very much, Sri Lakshmi. Let's go on to the second paper
Thank you, sir.
by Dr. Vinayak Rangan on AI used in daily and professional life among the pediatric surgeons in India. Please, Dr. Vinayak.
Yes, sir.
Please
Sir,
go ahead, sir.
can you allow me to share the? Yes, sir.
Please. Yes, please. Yeah, please.
1 minute, sir. Sir, can you see my screen, sir?
Yes, yeah, please.
Thank you for the opportunity. So today's paper is going to be artificial intelligence use in daily and professional life amongst pediatric surgeons in India. It's a survey. And using the survey, we have created a roadmap for how do we adopt AI into practice. And I must thank the IAPS leadership, Dr. Vikesh sir, Ramesh sir, and Bishwas sir for the opportunity. I think also Ankur sir for the opportunity of allowing me to present, and my colleagues Alish and Ashish. I just completed my MCH from SMS Medical College, Jaipur. So the background, so I think why are we doing the study? I think one of the key reasons why we are doing the study is because in the last 3 to 4 years, especially with the rise in generative AI, we're seeing an exponential rise. It's not a linear rise, it's an exponential rise. AI is simply pervading every aspect of our lives, in our daily lives. But when it comes to clinical practice, especially in low middle income countries like India, AI is still looked upon with a great amount of suspicion. And what we wanted to do was we just wanted to evaluate the awareness and perception of AI among pediatric surgeons in India, and also identify the challenges which we have, and also create some sort of a roadmap with which we could kind of go about doing this. So we wanted to explore necessary interventions for training pediatric surgeons in AI technologies, and how do we bring AI into surgical teaching, training, patient management, social outreach, and clinical academic research. We were trying to explore, but obviously we are at a much early stage of AI adoption, so we are not proposing any sort of major solutions at this point of time. So how did we go about doing this? This was a cross-sectional survey which was distributed to members of IAPS through WhatsApp groups. So it was a structured questionnaire. We had questions on demographics, personal and professional AI use, perceived benefits, challenges, and training needs. So 74 people responded, and the age group was pretty diverse. We had people under the age of 30, a few people under the age of 30, but even people 60 and above were able to respond to this survey, and that was pretty interesting. And most of them were general pediatric surgeons, but people had some focus on pediatric thoracic surgery or general pediatric urology. There were a significant amount of people who were students, pediatric surgery residents, who also responded to the survey. And if we kind of look at it, what was really interesting is that almost 25% of the people were early career pediatric surgeons who were less than 5 years from training. So that was pretty interesting. And this study was conducted in the era of generative AI, ChatGPT. So there was a significant degree of familiarity with AI. When we went through similar studies performed in other cohorts, like German studies on pediatric surgeons done about 5-6 years ago, people were not very familiar with AI, and that is kind of changed. And what was very interesting is that, despite the perception that, surgeons are not receptive towards AI, we found that a significant amount of surgeons were very positive towards AI. Almost 40% of them were very positive towards AI, and another about 40% were almost somewhat positive. So the amount of people who were negative was very less. And the idea that AI could enhance the quality of pediatric surgical care was also very much in vogue. So, but obviously, how often do you use AI tools in your clinical practice? And that's where we had some issues, because most people were not using it, and people, even if they're using it, were using it in a limited basis, once in a month or once in 2 months. And when it came to, actually feeling that has it improved outcomes in practice, that's where, people did not have much of an opinion, because they were actually not using it. So I think that was the major point of the survey. So, and writing emails, grammar checks, literature review, data analysis were the key uses of AI. And they felt that a significant amount of people said that, AI has kind of democratized the overall research pathways. We are in the global south. We are a lower and middle income country. For most of us, for almost all of us, English is not the first language. We don't think in English. If you ask me, I think in Tamil. So AI has kind of democratized, because now if you are using AI to just make a language check, I think that makes your research no less valid than a person who is, who is a first, a native English speaker. So, and a significant amount of people were kind of comfortable with using AI for research related tasks. So the biggest concern for people was data privacy and security, reliability and accuracy. As we know, ChatGPT tends to hallucinate, and obviously, ethical considerations when it comes to AI. So this particular team has also written a chapter in the IAPS textbook of pediatric surgery. What could be the ethical challenges when it comes to adopting AI in practice? So the biggest problem when it comes to ethics is the black box nature of AI. AI works, machine learning algorithms work, but how does it work? So that, unless people start to understand how does AI work, people are not going to adopt it. Obviously, when it comes to, using pediatric data, when it comes to children, the biggest issue is that children are kind of defenseless. They don't have control over their own data. It's someone else taking the decision. It's their parents. Are we really at a stage where parents can understand the implications of AI? So a major ethical question arises at this point of time. And when it comes to implementing current technologies, the commercial use of AI, many of the algorithms have been built with adult data. Is this data really valuable? Are we committing an ethical gray zone, entering into an ethical gray zone by using adult data to create pediatric algorithms? That is all a big gray area which we need to resolve. And as societies, we can collaborate, generate larger amounts of pediatric data, then these sort of queries are going to be solved. So the biggest takeaway was almost 75% of them were, very clear in saying that they wanted to receive further training or education. And even among those rest of those 25%, 20% said, yes, are you interested to some extent? Now, for us, that was the biggest takeaway from this. So this was the IAPS roadmap, where how do we want to create awareness about AI? So, using webinars, by lectures on basic knowledge of AI, what is machine learning, what is deep learning, starting from the basics, to assume that the 50 people here know what is machine learning or to know what is deep learning, and start off by talking about AI is to be, from my perspective, it's quite criminal, because a lot of us lack basic understanding, and it is our duty to educate people right from the basics. It can be the resident, it can be the professors, but when it comes to AI, most of us are novices. And even for the people who have written the paper, many of us, it took a lot of time for us to understand even the basics, and to say that we have understood something is also an understatement, or is an overstatement, to be honest. We don't understand AI as much as the experts do. So definitely we need online hands-on workshop to understand applications of common AI for daily and professional use. And just to make things simple, AI does not necessarily mean coding. There's a lot of no-code AI which is simplified. And if we learn how to handle data as surgeons, I think that's going to be a major, a big boost to this. So we need brainstorming sessions with AI expert researchers and young scientists and engineers. And I think there needs to be a lot of collaborative efforts. One of the reasons why West has succeeded in bringing AI is because they have universities. If you take, say, Harvard, they have fantastic machine learning teams, engineers, and they have a medical school. So it's kind of easier for us to collaborate. But if you take us, we have Rajasthan University of Health Sciences, we have Tamil Nadu MGR Medical University, if you kind of look at the Tamil word for university, it's Palkalai Kazhakam, which is, Palakalaigal. That is, many sciences work together. But modern medical universities have kind of defeated the purpose because we don't have many sciences working together. And I think collaboration between engineers, scientists, and surgeons is going to be very essential for doing this. And we definitely need to use, have online workshops on how do we help scientific writing using AI. And that's a problem because I see some of my teachers, some of fantastic professionals who have a fantastic understanding of the subject, but they are unable to have the language skills to bring out their papers. And I think AI can play a major role in bridging this gap. And we definitely need to work together as societies to create large scale data sets which can be used in AI. So we had a fantastic table on what could be the potential applications. It's reading this is going to be difficult, so I've kind of put it into slides. So it can be used in decision support and planning. We can have machine learning models to help in decision making process. I'm going to be explaining this in a little more detail. We can use it to analyze imaging. We can also use it for analyzing genomic data. And AI is being increasingly used to identify critical anatomy, perform real-time measurements to identify critical structures, like identification of a vas deferens while you're performing a laparoscopic hernia for a novice. You're performing a tracheostomy fistula. You want to identify the vagus nerve, preserve the vagus nerve, or you don't want to differentiate between the aorta and the esophagus. I think these are all real-time challenges which we face, and I believe that over the next 5 years, AI is going to play a critical role in identifying this. I know it sounds a little, futuristic, but I'm going to show you a couple of examples, just 3-4 examples, which will kind of help you understand, okay, this is going to be possible. Surgical simulation, already AI is kind of, we had a recent conference in AIMS and, we kind of had a virtual reality simulators, and AI is going to play a major role in this. Augmented reality in liver resections is already in place, and we could have, personalized AI recovery, because I think we are in the era of personalized medicine. So we use data from individual patients to, create individualized recovery pathways for the patient. So here is a study. This was in 2020. This was almost 5 years ago. They were able to identify biliary atresia using symptoms and just symptoms. And this was an algorithm which was able to do it with a sensitivity of 97% and a specificity of 91%. A recent paper, a Chinese paper, I could not put that paper, could identify biliary atresia from ultrasound images. It's a major challenge in India to do this because of PCP&DT regulations, but AI in pediatric ultrasound is expanding on an exponential basis, and they were able to perform slightly better, significantly better than novice radiologists, and almost equivalent to, they were non-inferior to an expert radiologist in identifying biliary atresia on ultrasound. Pediatric appendicitis, there have been almost 8 papers which have been published, which were able to identify appendicitis on a CT scan, thereby, expediting the treatment process. So this was a very interesting paper published last year in Journal of Pediatric Urology. They were able to predict the grade of, split the VUR into a high grade VUR and a low grade VUR using machine learning tools, using, radiological images. Like when I spoke about measuring intraoperative structures, I'm going to show you this thing. a significant part of AI is going to be in identifying safe zones and unsafe zones. So this is an image of a laparoscopic cholecystectomy. This was performed by our research team, where we were working in collaboration with IIT Madras at SMS Jaipur. We are creating algorithms to identify structures. So this is an image of a gallbladder during a laparoscopic cholecystectomy. If you're able to identify the gallbladder, if you're able to identify the common bile duct, we could create algorithms which could help tell the surgeon, okay, buddy, stay safe. You're not supposed to be going there and not going there. I see potential applications in identifying the ureter in hysterectomies, identifying the vagus nerve, identifying the aorta in tracheostomal fistulas, and a lot more. This is an ongoing study. We have where we were trying to identify the pediatric ureteric orifice during cystoscopy. We have reached accuracies of almost 80%. We are trying to increase it with more data. This is the actual image. The tile in the middle is the ureteric orifice, which has been marked, a segmentation mask, which has been marked by the pediatric surgeon with greater than 10 years experience. And the tile on the right shows the prediction of the pediatric ureteric orifice by the algorithm. If you can kind of see, it almost matches the same thing. So a major challenge in laparoscopy is the inability to measure oncological distances. This is a bariatric surgery by a very famous bariatric surgeon in the US. If you can see, he's measuring this thing, and he's saying, that metal part is almost 5 centimeters. So what I measured appears to be around 5 centimeters. So there was a study in 2022 which said that the degree of error was almost 33%. If you're measuring 100 centimeters, they were, underestimating it. They were, getting only 70%. And this was by expert bariatric surgeons. So what we did was we annotated around 2000 frames of the bowel grasper at various angles, split the data into 20% of the data was used for a testing set, and 80% of the data was used for training. And I will skip this part because this is a more technical part. What we used was convolutional neural networks. This is essentially mimicking how the brain works, and Transformer is just like the movie Transformers. It kind of enhances the power of these neural networks. And using this, we created something very elegant. We still have to reach a greater heights, degrees of accuracy. As you can see, the bowel length is being measured in real time. The mean error is almost 15% yet. And this is not 3D laparoscopy. This is plain old school conventional laparoscopy, a 2D laparoscopy, which is what 95% of the world still performs. And we have been able to, calculate the bowel length with reasonable amount of accuracy. Yet a lot of work needs to be done. And like I told you, this is the gallbladder being identified in real time. And the distance between the instruments is also being measured. And here, like we told you, that's me struggling with my left hand. I still need to improve. And as you can see, we are in a position at this point of time in the world where we are able to measure ambidexterity, tremor, what is the least common path of motion. So yes, I think the science is moving at a rapid pace, but we need to improve a lot more. So when it comes to the measuring of the intraoperative distances in pediatric surgery, Kasai's, choledochal cyst, bariatric in adolescents, the bladder size measurements, you want to, bowel tumor, you want to, measure the margins. I think I see a lot of potential. There was one more, fantastic use of AI, which I wanted to talk about. This was by an Indian, Siddharth Satish. He started this startup called Gauss Surgicals in the US. They were able to measure blood loss with a great deal of accuracy. This was, using simple physics principles. They created a standardized, lab pad, and they showed it in front of the iPad 2. This was an old iPad 2. This was developed in 2018. And they trained it using spectrophotometric data, which is, I struggle to explain technical terms with a little more ease, but I'll try to do this. What they essentially try to do was, so even if the lab pad is soaked with urine, saline, RL, or whatever, bile or whatever fluid, the degree of redness tells you the hemoglobin loss or the blood loss of the patient, how red the gauze is. This is simple computer vision principles. If I want to explain computer vision principles in simple language, it is like explaining how a dog is able to hear. We are able to hear only certain frequencies, but a dog is able to hear frequencies which are way beyond the human comprehension. Similarly, a computer can look at things which are way beyond the human field of vision. We are able to look at it is able to differentiate between the Hounsfield unit of 45 and 50, which is going to be impossible for a human radiologist. Similarly, a computer vision is able to differentiate between multiple shades of on a simple image. I think men and women struggle because I find women are able to differentiate between multiple shades of red on a lipstick, which I don't think a human male is able to do. So similarly, a computer vision is able to differentiate between different shades of red, and they trained it using humongous amounts of data, and they were able to use this. It is now being used in 110 ORs in the US exclusively for obstetric purpose. But I do feel that this could be of great use in pediatric blood loss, because here in pediatrics or neonatal surgery, even 20 ml blood loss is going to be significant. And if you're able to estimate the blood loss with a great amount of accuracy, I think it's going to be fantastic. This company has now been purchased by Stryker for an undisclosed sum. So, if you
Dr.
learn.
Dr. Vinayak, if I may interfere, the time is up.
Yes,
It's
sir,
already
sorry.
beyond 15 minutes your presentation is.
I'm sorry, sir. I think
No problem. We chose this because AI is the most upcoming, and more and more centers the surgeons for their knowledge, for their papers and publications are depending on AI in many, many ways, in general life as well as in the medical practice. So we chose this topic for it. So finally, what is the conclusion and what is your suggestion? Because there are a lot more youngsters who are going to join, and they know how to use depending on the AI much more than the senior people and all that. So what is it you are going to tell us?
I think, sir, I think the biggest takeaway is that the field is evolving rapidly, and we should not be resistant to change at this point of time. And I think it would be the responsibility of AIPS to take it upon itself and the members to conduct workshops, to participate in webinars, so that we can be a part of this revolution and not be left behind in this. And like my final slide was, I don't think you should. The term artificial intelligence is a misnomer. I would say call it as augmenting intelligence and not artificial intelligence. So I just want to finish off with a quote by Henry Ford. He said, if I asked people what they wanted, they would have said faster horses. I would not have ended making cars. So I think the revolution is already here, and I think we have to be a part of it. Thank you so much for the opportunity, sir.
Yeah, sure. Without the knowledge, we are all sucked into this AI and this dependency on the AI and all that. So no doubt that it's taking over the medical practice, the helping surgeons in their various radiological interpretations, the anatomical interpretations, on-table interpretations, even robotic surgeries kind of things. So nice presentation, and any questions from the delegates can be posted in the chat box. Next, Chandrasekhar can make 1 or 2 points.
Vinayak, interesting. So, how many people did you send this questionnaire, and how many responded?
Sir, we put it in all the groups, student groups, all the IAPS groups, and 74 people responded, sir.
Sorry?
74, sir, 74.
So does that itself tell you that many people are not into AI? Do you need a real study for that? That itself will tell you that at least when you did the survey, not many people were into AI. I am sure people will jump into the bandwagon very soon. No, this it's interesting about the ureteric orifice.
Yes, sir.
So I don't remember when the last time we had difficulty in identifying a ureteric orifice.
It is not difficult, sir. I think it's just that
really think an AI is required to identify the ureteric orifice, or then AI can identify the nostril to put the nasogastric tube, and maybe
I think that's a very important point, sir. In fact,
are we really curbing the surgeon's skills in such a way that a surgeon who does not know how to identify the ureteric orifice on a cystoscopy is going to perform cystoscopy?
No,
I
no,
mean,
sir.
I think this is my.
No, no, sir, I think it's a very valid point, sir. In fact, the same question was asked by a senior urologist when we presented at the ethical committee in our medical college. Sir, I think, to be honest, sir, we chose it because it's also a low-hanging fruit for us. It is not, it is something which cannot be identified by maybe a first-year resident or a second-year resident, but it is something which is not too difficult also to identify. So instead of going and attacking maybe something very a burning problem like say the vagus nerve in a tracheal fistula, which is going to be significantly harder for the AI to crack, to build the algorithm, we wanted to start off with a low-hanging fruit and to demonstrate to the world that yes, this is possible. Uh, I mean, I don't think that there's going to be a commercial application for this, to be honest. But this is just to learn how do we annotate.
Pilot project.
It is a pilot project, sir.
Fair enough. But even in that, you had only 80% accuracy till now.
Yes, sir. Yes, sir. We had see the when we are talking about we are not going to be performing it on a normal bladder, sir. We see bladders with the trabeculations. You know, the algorithm is going and identifying some of the trabeculations as the orifice. So I think those were the bladders where we are facing challenges, and those are the bladders where we actually wanted to be of help also. We have been performing this study for almost more than 1 year right now, sir. More than 1.5 years, in fact. We have hit about 70 to 80%, 75 to 80% accuracy, but we still definitely want to publish it when we hit, say, around 90%, hopefully.
I think you should have 100% if you're doing with AI.
We are still a little far away from going 100%, sir. I mean, it's going to take a lot more time. Yes, sir. I think it'll be a computer overlay, sir. I think Arvind sir has asked about. I think that's what we are aiming at, sir. And there have already been tools. There has been a Japanese startup which has kind of started identifying the ureter, especially for gynecologists who are kind of, who tend to injure with all due respect, maybe there is a little higher rate of ureteric injuries when it comes to hysterectomies. So they have kind of created a software where during the surgery, if you press a button, just like how ICG works or infrared works, it is able to identify the ureter when a hysterectomy, lap hysterectomy is being performed. So I think that is going to be the future of surgical AI in the years to come.
Fair enough.
Thanks, Dr. Vinayak. Shall we go on to the third paper because it's already the time? Thank you. Let me welcome Dr. Jamir, who is presenting on Mesorex bypass from Narayan Hrudayalaya. Dr. Jamir, please.
Hello, good evening, everyone. Thank you for
Please
giving me an opportunity.
Yes,
Greeting from Narayana Health, Bangalore. Today, I'll be talking about our experience with Mesorex bypass, what all we have done so far and what we felt about it. All of us know that extrahepatic portal vein obstruction is the classical chronic obstruction of the portal vein. The vein surgery is the shunt surgery, which we all keep talking about, which aims to reduce the portal venous pressure. Now here we are creating a shunt between the systemic circulation and the portal circulation. But then a lot of articles of late are coming about regarding the problems with diversion of blood from the liver, sequelae like MHE, that is minimal hepatic portal encephalopathy, portopulmonary syndrome and all. And Mesorex bypass has come up as a physiological cure. But despite being there for a long time, it is not being done as commonly as any other shunts. And keeping this in mind, we thought we will do a study to see what is the feasibility, why is it not being done so frequently, what is the effectiveness of this Mesorex bypass in children, and we would also like to share the experience of the surgical steps of this surgery. So let's go. I'll take everybody along through one by one of this. What we did was a retrospective observational study. All children of EHPVO who underwent Mesorex bypass were included. The study was almost a period of almost 10 years, and the data was accrued from the medical records. The children with EHPVO who were considered for Mesorex bypass. So before we included patients, first we tried to see which patients we can do Mesorex bypass. So all the children who had asymptomatic splenomegaly, mild to moderate hypersplenism were included. Severe patients with very large spleen, symptomatic or severe hypersplenism were excluded from the study. Patients without liver fibrosis, and on imaging, if it was a patent superior mesenteric vein of a diameter of more than about 5 millimeters and evidence of patent left portal vein in the rex recess were included for the study. evaluation was the standard for all patients for shunt, that is the hemogram, biochemistry, endoscopies. And for imaging, we used ultrasound Doppler and triphasic CECT of the abdomen. The basic crux in this thing for all patients with Mesorex bypass was to check for the patency of the left portal vein prior to surgery. We used Doppler as the first line of imaging, which said that whether there was what is the status of the portal vein, splenic vein, and the renal vein. Doppler generally was not very useful to identify the left portal vein. Contrast enhanced CT, triphasic CT was used, which helped us in many a times to tell us whether the left portal vein was patent or not. Ideally, wedge hepatic portal venogram with use of contrast or CO2 was better, but that is with hepatic vein catheterization, and that was not used in our study. That itself has its own problems of requiring of anesthesia and availability. But at the end of the day, there were situations when we did a CECT which said that the portal vein was patent, but when we did surgery, the Rex and on dissection of the Rex recess, we found that the left portal vein was not patent. So finally, all the patients who were included were actually finally were the patients who were confirmed to have a patent left portal vein intraoperatively. Let's go through the surgical steps quickly. The patient position was supine, neck extended because we wanted to harvest the IJV. Mercedes-Benz incision is preferred by us. The initial step, basically the liver is suspended and we follow the umbilical ligament into the Rex recess. Now, an important step here is that we have to dissect between the third segment 3 and segment 4 of the liver, and there's generally a parenchymal bridge. Instead of just dividing the bridge, we prefer to resect a part of the liver on either sides. This actually opens up the liver surface Rex recess for easy dissection. Also, at the end of the anastomosis, at the end of the shunt, at the end of the bypass, that doesn't press or that doesn't compress onto the graft. So that's why we prefer to resect that part and expose the Rex recess. The portal vein, the Rex recess is dissected and we sloop all the tributaries of the portal vein. We make sure we sloop them individually. We do not ligate any of them because this is the one that allows the inflow into the liver, and we sloop it and and create adequate space so that even a clamp sits behind it. Next, once this is done, the next part of the surgery is the superior mesenteric vein, which is accessed in the infracolic compartment following the middle colic vein. And it is dissected for almost 3 to 4 centimeters so that a clamp can securely sit and we have adequate place for anastomosis. The next step would be the creating a space from the liver to the superior mesenteric vein. In this, we create a retrogastric tunnel, which is pre-pancreatic. And here also, we make sure we create adequate tunnel so that there is no compression of the graft. For the graft, most commonly, we have in our experience, we have actually used IJV in all the cases. For dissection, we need almost the whole length of the IJV right from the origin till the drainage into the subclavian. So generally, it requires two transverse incisions in the neck, and the whole IJV is harvested. And the anastomosis, the first anastomosis we do is the distal end, that is at the Rex recess. The Rex recess, as shown in the diagram, we prefer to cut in a T fashion. So once we do this, it opens up like a triangle. And then the vein also, we take 3 cardinal stitches so that the whole anastomosis is wide open and we are able to access all the areas and do the anastomosis so that it sits like a big, like a funnel on it without causing any compression. Generally, protein 6O or 7O is preferred by us depending upon the age of the child and the vein size. Once this anastomosis is done, we allow the blood to flow across, put a clamp and see. Once we see this flow, we are sure that the left portal vein is patent and there will be good runoff distally. The next step would be the liver is dropped down. We bring the graft through the retrogastric, through the tunnel that we have created. Make sure there are no twists, there are no kinks, and then the anastomosis is done with the superior mesenteric vein using proline. Post-operatively, our protocol is to give low molecular weight heparin for about 7 days. We overlap it with aspirin, and which is continued for almost 3 months. We do a Doppler prior to discharge, which is around 5 to 7 days before discharge, just before discharge, make sure that shunt is patent. The children are followed initially 6 monthly and then yearly. And at each follow-up, depending upon the previous condition, the complete hemogram, basically to look for hypersplenism, to ultrasound to look for the spleen size, and to look for the shunt, Doppler to look for the patency of the shunt is done. We have evaluated a total of 83. We have done total of 83 shunts over the past 10 years. This is all patients with EHPVO. And we analyzed the different types of shunts that were performed. And the most common were the spleen preserving, that is side-to-side linorenal, and the DSRS shunts. The next most common was the central shunt, and the Rex bypass we had done only in about 10 out of 83 patients. One interesting thing that we found out in the age group of this was all the patients of Rex recess on an average were less than 5 years. The patients with spleen preserving surgeries were in the age group of 5 to 10 on an average. And the patients who had central shunt, that is splenectomy was done, were about 10 years. And this this difference was actually found to be statistically significant. And it goes clinically, if you feel that, the older the child goes, what happens is the spleen becomes bigger and bigger. There's massive splenomegaly, significant hypertension. They end up requiring a shunt. And for Mesorex bypass, generally it was done in younger children actually. Another interesting thing is why Mesorex bypass is not done most of the time. Even if it is considered, we were able to do it. Only about 17 patients were actually considered for surgery for Mesorex bypass. That is, after all the pre-evaluation, making sure the spleen is good, making sure there is no significant hypersplenism, and on imaging, if the left portal vein is patent, only 17 patients we were able to plan for Mesorex bypass. And out of the 17 patients, only 10 patients had the portal vein patent during surgery. So the CT scan, the triphasic CT that we do, is definitely not very reliable to make sure to help us to do to identify which patients Mesorex bypass is done. So this definitely says that feasibility of Mesorex bypass is very, very less. Age distribution of Rex patients, as I said, the average age was about 4.5 years. More than 7 out of 10 patients were less than 5 years. And this again difference was found to be difference was found to be statistically significant, that generally Rex patients, it is done in children or feasible in children less than 5 years. The post-operative, most of our Rex patients did well. 2 children who were actually older had early perioperative ascites. We were worried whether there was a block in the shunt, and Doppler was done to make sure the shunt is patent, but they both responded on conservative management and they settled. No other immediate complications. We had a follow-up of almost 5.5 years, ranging from 1 to 132 months. Almost all the patients did well. One patient came back with hematomasis almost 2 years post-surgery, and on evaluation was found to have a stenosis at the portal end of the graft, and he actually responded very well to endovascular balloon dilatation. So at present, all the patients are doing well, shunts are patent, and hypersplenism in all the patients has resolved. I would quickly go through the basics of Mesorex bypass. Basically, as compared to other shunts, it reduces the portal pressure as well as maintains the hepatopetal blood flow, which is what we are looking at. Prerequisite, as I said, is a patent left portal vein. And also, along with that, you need a robust communication between the right and left intrahepatic portal system. A lot of studies have come with the feasibility of it. It is said that, Rex recess wedge hepatic venoportography is done, and in that, the feasibility is only about 29%. How do we recognize which patients have a feasible anatomy? CT scan sensitivity is found to be very less, about 30 to 40%. Wedge hepatic portography is much better than this. It's almost 72%, but still it is not easily done, and again requires anesthesia, as I said. And finally, for patency, many times it has been found that the average age less than 5 years, it is found to be more feasible to do in such children. The conduit most commonly used is the IJV. It is an autologous graft, it grows with a child, does not require any anticoagulants. Alternative grafts have been used, saphenous, splenic vein. People have actually dissected, done splenectomy, turned the splenic vein towards the portal vein and done it. But then generally it's not easy, they have a high risk of thrombosis and stenosis. Synthetic grafts have been used, but then they require prolonged anticoagulation. So IJV is the most commonly used. Outcomes, a lot of studies have been done which says that the shunt-related complications to Mesorex bypass, even though we say it is a difficult surgery, there are two vascular anastomosis. The overall shunt-related complications with Mesorex bypass are also comparable with other surgeries. But definitely, if you look at other complications like minimal hepatic encephalopathy or hepatopulmonary syndromes, Mesorex bypass fares much better. So as of now, a lot of studies have come, and it has been considered as a gold standard whenever feasible, and has been proposed as even pre-primary or primary prophylaxis against portal hypertension bleeds in children. So in the end, I would like to say that definitely Mesorex bypass is the only surgery that is curative for EHPVO, feasible in a small subset of patients. Evaluation again is a problem, most commonly done as a CT or an MR. But finally, it is during surgery whether we have is feasible or not. So one should always have a backup in case we are trying for REX. If portal vein is found to be fibrosed, then we should have a way out. And the outcomes of Mesorex bypass are definitely very good, but especially in younger children. So if you are planning for it, the earlier we do, the better it is. Thank you.
Thank you, Dr. Jamil. Just one point. Why is it not done for many patients? Out of 84, done only 10 patients were suitable. There is some publications that say that even for hypersplenism, even for large spleens, moderate sized spleens, the erection can be done. So why is that in your series it is not included in all these cases?
Yeah, I think, sir, as I said, I think the basic problem is the type of patients that we come across. And we have excluded patients with massive splenomegaly and severe hypersplenism because those are the patients who invariably end up would definitely require a splenectomy for as a part and parcel of the treatment. So those patients were excluded from the study. And once they are out, we evaluated all the other patients for the feasibility of REX, and in that again a lot of patients had fibrosed portal vein. Left branch of portal vein was fibrosed on the imaging, and that's the reason we went up to them. So I think at the end of the day, the younger patients we get, I think it is more feasible. Once we get patients above 5 years, above 8 years, 10 years, the feasibility would become less, and our numbers have actually comparable with that to the literature also, which also feels that I think if you're looking out for REX, we should start looking early rather than late.
So first you look for the patents of the left portal vein, and if it is patent, you go for IJV and conclude the surgery.
Yes. I think the first dissection is dissect out the REX recess and see if the portal vein is patent. Only then we proceed. Otherwise, we end up we have a backup of either splenorenal or something else.
Any long time sequelae of removal of IJV on the side?
Of late, we have not had any problems, sir. We've kept all our patients on follow-up. One IJV we have removed. Generally, pre-operatively, we evaluate, we do the Doppler of the neck, make sure both the IJVs are patent. And we have removed the IJVs of all these fellows, and all of them are fairly doing well. There are studies in the literature which say that, IJV should not be removed or can cause problems in patients who have had hydrocef or Arnold Chiari malformations. Also, there is the risk of some pseudo tumor cerebri, but generally we have not found any problems so far. So I think we are quite comfortable and quite happy to take the IJV. The diameter and the length, it actually most of the time actually matches it. So it actually appears that it is made for that sometimes.
The training center for Mesorex bypass in your place, Narayan Hudayalaya. How to mobilize the younger fellows to come and observe those erections in a short period of time?
So I think whoever is interested are always welcome. Training for REX bypass, I don't know, as we do REX bypass, but as you see, we have done about 10 in the past 10 years, and we have done more so in the last recent time. But to come and train for REX research in a short period, I think we'll see, sir. Next time, if there's a conference, we had done a conference on a REX Mesorex bypass 3-4 years ago. Maybe try one more.
At one time, we looked desperately for any centers in India which train or at least show us these centers for the REX bypass and all that. So this kind of publication is the first thing from Indian center. Hearty congrats, and the success, as you say, is very much physiological for the EHPVO. Well done.
Thank you so much. I think the credit goes to Dr. Ashley and Dr. Sanjay Rao, sir. I think they have taken the program across and they've been doing, and I think Sanjay Rao, sir, has gone across, and we have shown the surgeries as well in one different places. So I think
sure.
Main credit goes to them.
Sure. Dr. Chandrasekhar, please.
Yeah, very interesting, very nice, fantastic work. I have one query. We do some shunts, but mostly we do as you said, the patient, by the time they come to us, they have large spleens and they have significant hypersplenism. So we are almost forced to do a central shunt splenectomy and a central or a proximal shunt, whatever you call it. And these are usually older children. Younger children don't have the size of the splenic vein to actually do a central shunt most of the times.
Yeah.
So here you are first making a large incision. You are making Mercedes-Benz kind of an incision. And then you are opening up everything, and then you are dissecting the rex recess. And then suppose you find that it's a 4-year-old child. Your average age was 4 years in mesorex shunt. You find that there is this is not a portal vein, is because in 17 patients out of 17 whom you chose, only 10 you could do. So 7 probably had the left portal vein fibrosed already.
Yes.
So how do you manage with a small splenic vein? I mean, if you want to change your plan, then what do you do?
Sir, as I said, generally
Splenic vein is not fit for a shunt normally in these children. They're very small children, so splenic veins are very small.
Yes, yes. So it also depends. We keep a backup. We keep this thing that in case this is not there, what other options we have. All these patients whom we have tried, have mild to moderate. So we try to preserve the spleen. So we look at it in two ways. So if the splenic vein is, it depends upon how tortuous the splenic vein is. So if we find the portal vein is fibrous, if the splenic vein is tortuous enough, I think our next preference would be to do a side-to-side splenorenal. And for that, we don't need a very large the diameter. But 5 mm of splenic vein also is good, because this would be a longitudinal cut on the splenic vein. In case the splenic vein is still not very tortured, it's quite straight, then we actually think whether we think about DSRS or distal splenorenal, or we go in for a DVAS. Most of the time, side to side or DSRS is what we have gone. We have got away with either of these two.
But why do you need to take so much of a risk and start deciding on the operating room and these patients when they can be very well managed with endoscopy for quite some time?
So, managed with, sorry?
That's one argument. Against doing surgery aggressively for these children, isn't it? Because they can be managed. The varices is the major problem. They don't have liver problems. Varices is a major problem, and the varices can be very well managed by endoscopy for years together. So to be aggressive, open the abdomen, then decide the portal vein is fibrosed. Oh my God! Now we change the plan. We are not sure. We do a DVAS. I mean, I'm not an expert in this, but then I'm just wondering whether the gastroenterologist can take care of the varices.
No. So I take your point. I think endoscopy can very nicely and in today's era very efficiently manage all the varices. But I think varices is one thing that we see which is very obvious and very staring at our face in patients with EHPVO. More than varices, there are a lot of other things which are running behind, which also need to be taken care of. And one of the most important thing which we find is failure to thrive in all these children. And if that needs to be taken, the curative treatment has to be done. So many times we feel that, it is not just varices, it is the overall portal hypertensive problem which needs to be taken care of. Also, in the long term, there are a lot of studies which are coming up. If they're not operated, being managed endoscopically at 15, 20 years of age, they end up having portal cavernous cholangiopathy, and that is actually a nightmare to manage. So I think the sooner we treat them, cure them, I think all the other sequelae complications are taken care of. So generally we feel that varices is one of the things.
What I am saying is probably the Ankur commented that they actually do the other radiological studies to confirm the patency of the left portal vein before they go ahead for the surgery.
Yes.
Maybe that may be better, no? So that you are definitely know what you're doing rather than trying to choose on table what to do. And I'm just wondering, that's all.
No, I think
more expertise than all of us. Yeah.
Dr. Sanjay wants to make 1 or 2 points here. Dr. Sanjay, please.
Thank you very much.
Yeah.
I think, VVS, you make a very valid point. I think we should not be opening these patients up for surgery unless we have an exit. We have committed that they should have a shunt. Ideally, they should have the first option is a mesorex bypass. If that doesn't happen, they should be able to have a selective shunt. So the anatomy must be conducive for either of these. So if you have a situation where you will end up doing a devascularization because the splenic vein size is not good, we would wait. They would have endoscopic sclerotherapy as you suggest, and we will screen them after 6 months, after whatever period of time. So because the exit for a Rex procedure cannot be a devascularization, or it cannot be a central shunt. It has
That is
to be a
exactly what I
selective
was
shunt.
saying. That is exactly what I was saying.
Yes, so I think the point that you make is valid, and I think that is something that we do. So even in the patients where we have had to go, we have not been able to do the Rex shunt because of the vessels not being patent. They do have a selective shunt, either a side to side or a DSRS. Ideally speaking, if when these options are not available, we should not be opening the patient just to see that. So that thing about just opening to see, I don't think is not what we would do. So there is an exit, and the exit has to be a selective shunt. It cannot be a non-selective shunt or a devasc. That is one point. The second point is about the hepatic venous, sort of retrograde portogram that Ankur was mentioning. So last couple of cases we have done that. It's easy to do, but it adds cost. And finally, again, it just gives you an indication that it might be possible, it might not be possible. Ultimately, the dissection, you need to do that dissection. So that's the issue with this. So I take your point. So I think you must have an exit, and the exit should be a selective shunt. It should not be, it should not be a central shunt or a devasc. I hope that answers your question. The other point that was made was about IJV. There is one report in literature about a sort of a middle-aged lady who had an IJV removed stroke thrombus as a part of something, who developed what looked like raised ICT, intracranial pressure and things like that. But that when you go through that it's actually quite a complex thing. It's not just a simple thing. She had many other comorbidities, etc. But yes, it's a valid point. I mean, if you take off one IJV in early childhood, then what's going to happen over the years? We don't know. I mean, I'm not so worried about the fact that they might develop pressure symptoms, because there is adequate collateralization and the brain will drain. It's just that if something happens to the other IJV, then what is going to happen? You put a central line and it thromboses and things, then what's going to happen? So that's something that we would have to think about. But unfortunately, at present, there is no other substitute which works as well. People have demonstrated, as Zamir mentioned, various other shunts, but the only people who have demonstrated that shunt are the people who have written it. Nobody else has been able to demonstrate, either do it or write about it. So it's not standard, and it doesn't give consistent results. So we are still left with the IJV, which works very well. In the long term, in adulthood, if they require the other IJV for something and it gets thrombosed, then I don't know whether there is literature, but it's not unusual for IJVs to be removed in adulthood. And when you have neck dissections, a lot of the time they take it out. When they put lines, they get thrombosed. So I guess there are enough pathways to protect the brain. It's unlikely that it's going to be a primary problem, though. Yes, it is unphysiological. So those were the two comments.
If I can comment, VVS.
Yes, please. Yes, please. Yes.
Sanjay has brought out a very important point. I would like to comment upon the patency or availability of left portal vein. Undoubtedly, you need to have a gold standard to demonstrate it as retrograde portal vein demonstration. Like you introduced from the neck and enter with hepatic pressure and that. It also requires a lot of skills, expert interventional radiologists to diagnose, to give you the correct information. And in the post-operative period, if such shunt gets, he should be available for you to dilate the stenosis as they have done in one case. I also experienced this. I had to run pillar to post because of that. Interventional radiologist has to be there around with you, who is equally expert. So that is the important part. Secondly, if you see all these cases, they come to surgeon are when they are pushed to the corner. Directly they will never come to surgeon. They will be going to first gastroenterologist, and when they will be already trying and doing all their best with the endotherapy and the pharmacotherapy, and then they are pushed to us. So we need to do something for them. That is number one. So we are not doing as if some dissection is going on, and in the end, we are trying to do something. So that is another very important point. Third important point I would like to bring is, if you find, before going into the depth of dissection, if you open the free end, that ligamentum teres, and put a small feeding tube or a cannula and introduce on table contrast, a good number of times you can see the anatomy very well, like what we do per op cholangiography. That is point number 3. And point number 4, uh, if everything fails, if your luck is too bad, even you do not have shunt for even vein for the makeshift shunt, you can go for modified Sugiura procedure, which has got again very nice long-term outcomes. A marginally raised post-operative recurrence of varices more and the bleeds more, but then overall relief, overall benefits of shunts what you get are also available with modified Sugiura procedure. These are the points which I thought I would make. Thank you.
Just a couple of comments. I think the point that Raju brings out is important. I think what needs to change is a mindset, because currently the surgery is being treated as a bailout after endotherapy fails, or for whatever reason the child has a complication in endotherapy. Endotherapy is very good for the varices, but ultimately they develop other complications, and because of that they are sent for surgery. And by force, when that happens, these people are usually in their late first decade, or in adolescence or teenage. So by that time, we have lost whatever opportunity. The physiology has changed so much that it is impossible to restitute normal physiology. We are always going to do a palliative procedure. The only thing that I think, with the message that we have to push, is that when the patient comes to you first, generally portal hypertension presents in early childhood to the gastroenterologist. It's very unusual for a portal hypertension EHPVO to present at 10, 11, 12 years for the first time. Most of the time they have presented earlier and they have been seen by the gastroenterologist. So rather than automatically deciding that every patient should go to endoscopic sclerotherapy, you do the first sclero, control the bleed, and evaluate for whether surgery is possible or not at that stage. If you go earlier, as was based on the paper that came out from ILBS, if you are going to look at children less than 5 years of age, you have a 12 times higher chance of finding a patent portal vein. Beyond, if you go above 5 years, the proportion falls by 12 times. So the only message that we are trying to convey here is that when the gastroenterologist sees a child for portal hypertension for the first time, yes, do the endotherapy for the first time, finish the first round, then image the child to see whether anatomy is conducive for a corrective operation. Because if you do the corrective operation, you have cured the patient. There is no more palliation. Even if it is possible in 3 times out of 9 or out of 10, it is still worth the trouble, because all that you are doing is one extra CT when the child is young. So that is the only message that we have to convey, because they, when I presented this and discussed this with the gastroenterologist, they got very upset, saying we have been managing this for years together. What is this new operation you are telling us about? So the only message is that there is no need to change anything. Just after you finish your first round of sclerotherapy to control bleeding, please image the child once and see whether it is possible to do a corrective procedure. If not, continue to do what you're doing. That is the only message that I think, we need to convey to the gastroenterology community, because these patients are going to come to us from gastroenterology. They are not going to come to us from the street.
So when the child presents before 5 years of age, at the youngest age, whenever you diagnose AHPVO, and it is the time for the surgeon to evaluate for the possibility of mesoerection.
I mean, they can get the CT done, and if the CT and the Doppler shows a positive thing, then you refer it to the surgeon. If the CT scan says no, nothing is positive, well, go ahead with whatever you're doing. So that's the only message. So even if you cut down by 30%, it cuts down their endoscopic sclerotherapy workload by 30%, and you're curing 30%. You don't have to palliate them, and it is still a significant number. It's not a small number.
Younger the better for mesorex. That's what.
Correct.
Yeah.
What about the slat worthy shunt? It is not worthy.
Which one?
the cavo-mesal or mesocaval
Yeah,
or
I
the
think,
mesocaval H graft.
I think we have done them on 2 occasions because that was the only vessel that was patent. And the patient, they were not able to do, their child had gastric varices and things, and they were not keen to continue to manage. Yes, it is done. If you keep a smaller graft, it is thought to be partially selective. So it is done, but it's not common. It's not common. I think it is. It's all. So a small diameter one is actually preferred by before tips came into the picture. It was a very popular shunt amongst adults because it would partially divert, and if there was a problem and the patient went to transplant, it was very easy to ligate that shunt off. Once tips came, I think that thing has really gone off. So it's very rarely done.
Gladworthy was a pediatric surgeon. The one who described that shunt was a pediatric surgeon.
I mean, I didn't know. I think in that series, what is there, we have done it on 2 occasions, both of which because the splenic vein was not patent and the patient did require surgery because of endoscopic challenges.
Yeah, particularly as a rescue shunt after either failed endotherapy and they do not have answer, or patient had already undergone splenectomy devascularization and again posed with massive bleeding, and you have no other option but to go in sort of
Yeah.
a rescue type of a. But it's not a very effective portal hypertension decompressive shunt. Therefore, slowly it has taken a back seat.
I think the intervention guys have got into the act here, and tips is good. It's a good bridge with much less morbidity.
Yeah. Another point which I thought, since we are discussing and bringing this smaller age, this is one area where I feel where as a pediatric surgeon, everything is taken away from us by individual organ specialists. Here is an opportunity to bring back to the surgeon's fold portal hypertension again, where the long-term outcomes are so good, provided you learn to do this surgery well in a multi sort of disciplinary team, the outcomes are really very good. So this is good opportunity for us to intervene early and bring it back to the fold of surgeons, portal hypertension, which has gone out of our folds.
Yeah, I agree. I agree.
On a lighter note, Sanjay commented that even if you take out one IJV, the brain still drains. But brain drain is a problem, isn't it? That has been a big problem for India, at least.
So now it's a reverse brain drain.
Yeah.
You start doing it.
Yeah, good. Yeah, thank you.
So
Fantastic work, Sanjay, as usual. Fantastic work, Narayana and Sanjay.
Yeah, thank you. No, it is interesting. I think I should make this point. There was a paper from Assam about in the early 2000s where they discussed their experience with shunt in a relatively far-flung medical college. It was sort of way and beyond, and they have described two mesoportal bypasses in that paper, from Assam. They had about, they had quite a good number. So that was the first report I read actually that came out from India. So it's sort of buried in wherever that thing was. So credit goes to them. I think it's in Assam. I have the reference.
Yeah. I also have read that. It's a very good article.
Yeah.
Good. I think if there are no more questions, then Vijay, are you around?
Yes, sir.
Word of thanks and moderators, and I can discuss about the winner paper. Yeah, go ahead, Vijay.
So, thank you, dear all respected moderators and presenters from AIM Jodhpur and SGPJ and Bangalore. No, I think other than moderators, Secretary General, President, all can exit from the meeting for selecting the best paper.
Thank you, everyone.
Thank you, sir. Thank you.
Very interesting discussion on all papers.
Rasik sir.
Yeah.
Thank you.
विकेश सर हैं
नहीं है, विकेश नहीं है.
Uri hai. What should I do?
So we are
Just
supposed to
make me
leave, right?
moderate.
So,
No, I mean make me host, and you can leave.
thank you. Thank you.
So, uh,
Where Chandra, Srinivas, and me will continue the meeting. Others can leave.
okay, sir.
Yeah.